Well, good afternoon, everyone. Welcome to Citrus and today's presentation. We're delighted to have you here, particularly given, for those of you who aren't at Berkeley today, we have some inclement weather, which we're both delighted to have rain, but it does make it a little more difficult to get here. But our speaker, Jana Katz-Bell, has been able to make it down from Davis very nicely, so we're very fortunate to have her speaking to us today because of the expertise that she brings to us from our fellow campus and participant in the Citrus family. Jana has been so involved in the area of telehealth, telemedicine, which is really a huge and pressing opportunity within the Affordable Care Act environment, and over the coming years will be ever more central as we see changes in healthcare. So Jana comes to us with a great deal of experience and some very interesting observations from a very practical perspective, which I think everybody here today will appreciate and challenge us in terms of thinking how we can move telemedicine ahead and where some of the crossovers are with from a multidisciplinary perspective. So I'd like to quickly introduce her. Jana is Assistant Dean for Interprofessional Programs at UC Davis and within the UC Davis healthcare system. She has a joint appointment with the School of Medicine and the Irene and Betty Moore School of Nursing, both of which, again, are central in the Citrus organization in terms of our healthcare initiatives. She's been working with Dr. Tom Nesbitt, who's been the acting dean of the School of Medicine for a number of years now, in terms of building out a world-class telehealth, telemedicine program, and has been extraordinarily successful over the last 20 years to bring one of the premier programs to California. She's involved with statewide and national telehealth, telemedicine efforts, serves on a number of programs. One of those that we'd like to mention is the Center for Telemedicine and eHealth Law out of Washington, D.C., which does set some wonderful policy parameters in this space. Jana, we should also acknowledge, was a significant contributor in bringing the Irene and Betty Moore School of Nursing to the UC system and at UC Davis, bringing a $100 million grant into the system to create a premier research nursing center, which we're thrilled to have and be able to collaborate with the faculty under the leadership of the dean of nursing at this point. Jana, her background extends a number of areas. She's a graduate of UC Davis, but also from here at Berkeley, where she received her public health degree. So without further ado, I'd like to introduce our speaker today, Jana Katz-Bell.
Thank you. I feel like I'm running up to the stage like the Price is Right. I'm going to win a prize. Thanks, David. I've been at UC Davis now for 18 years, and I've really had the pleasure of working with two extraordinary leaders, Dr. Nesbitt for 18 years, as David mentioned, and now Dean Heather Young. But the Citrus relationship is instrumental, again, to both of those schools, as mentioned. And so what's actually happened, I realized as I was combining my thoughts for this talk, is I'm not even sure where some of my slides came from. They may have actually come from people in the audience because we have been sharing ideas and promoting different models of care now for, I think, upwards of 5 years or so. So if you see your work in my slide, I have done my very best to give attribution to these collaborations, but I hope you'll stop me and say that's my work and I have something to contribute. I'd really welcome that. So I know that David and Steve DeMello, who's not with us this afternoon, are going to see some of their work in these talks, but again, it's a reflection of our deep collaboration and our common mission and goal. The title of the slide of the talk is worth just commenting on because I couldn't decide what word to use because this field is somewhat schizophrenic. So you may hear the term telehealth, you may hear telemedicine, you may hear eHealth, connected health. People have a lot of opinions about what falls into these different buckets, and I don't really care. So I decided you can call it whatever field you want. We are now using the term technology-enabled health or technology-enabled healthcare as our new umbrella, all-inclusive bucket. But I will try my best to use some consistent language as we go. So what I thought we would talk about for the next 30, 35 minutes or so, I'm going to give you some guiding statements that really drive us really every day, our guiding principles. And then I'm going to talk about maybe where we've been in this field of telehealth, eHealth, connected health, etc. I might just use telehealth. It's the easiest one to blurt out. Where we've been and where we're going in key health environments. We often think about healthcare as a hospital. And that, of course, is not the case as we go forward for many of us. Then we'll have some remarks about the policy implications in these different care settings, thinking about the before and after, because I've spent the last even 3 or 4 years really trying to understand and drive, as the title implies, things that go from pilot and research and implementation, examination, to scale. And why a lot of these applications have not gone to scale in the last 20 years, and why that might have been, and what's coming in the future that might allow us to take some things to scale. And then there's a quiz. It's not really a quiz. It's a discussion, but I'm going to pose a question or two to all of us. So with that in mind, and the introduction recognized that I am not a researcher, and I am not a policy maker. I'm an implementer, and I've been an implementer. So my lens is from somebody in the trenches or leading projects, and I realize that's a really different lens. But this field is very interdisciplinary, so I was delighted and honored to have the time with you today. How many of you are engineers? I was told a good number. And how many are maybe from public health or the health sciences? So most of you are engineers, so please have me pause if I start using health lingo that isn't useful to you, and I'll stop at that. And David will translate. So this is a guiding principle for us that's really interesting. So as the explosion of new knowledge in health and health sciences is creating a greater disparity. So you would think the more we know about what causes cancer or blocks cancer growth, we would see a huge increase in health, but we don't. And the problem is the adoption of that science into the world is very, very difficult in terms of the haves and the have-nots. So, for example, if you have cancer and you live in San Francisco, your chance of having the best and most innovative care is much greater than if you live in Weed, California, and there's a town called Weed, California. So we're actually creating more of a disparity, and that bothers us and concerns us. So the idea is that telecommunications and information technology can help us deal with that growing gap between and distribute information to where it is and where it isn't. But we are applying technology to a broken healthcare system. I recognize that most of you don't work in health, but you are all health consumers. And I'm going to take a leap of faith that those of you who are health consumers have had or had to navigate for someone you love a difficult health situation. We have a difficult situation, a difficult system. But we're trying to use technology to address it. But the issue is, and this is actually a citrus, I'm going to now present a couple of citrus slides because we share in this vision so much, that we really want to use technology not on the current broken, difficult system, but to drive new models of care. So again, how do we do that? We need transformation. This slide, I think, was actually developed here, and Dr. Nesbitt felt so proud of it that we share it, and I hope it's all right to talk about. And this is getting at pilot to scale. Now what we do is we're responsible for ourselves as individuals. We tend to treat in institutions. We are really good. So UC Davis is a tertiary hospital with a level 1 trauma center and every specialist and subspecialist you could possibly name. We are really good at tuning you up and sending you out. We are not so great at managing you with your partnership in your home, especially if you're an older adult with complex health conditions. We focus on professional caregivers rather than the growing number, and this is Dr. Lindemann's particular area, the growing number of family caregivers and the partnership that has to exist to help keep us all healthy. We tend to finally just accept fragmentation. It's a difficult system, and we do workarounds. And we use technology to support the current process. Where we would love to be is we would like to manage populations. And if you think about managing populations, where in the world and where in the U.S. we're getting really good at managing populations, what we can learn from that. We want to treat in the home and the community, and we want to, again, use a broader network of caregivers to help our families and ourselves. To drive integration, so the more technology we have, the more fragmented we might get in terms of the apps that we use and the different kinds of technologies that we're now using to self-manage but don't connect with the rest of the world. and we want to use technology for disruption. This is an interesting slide that you may or may not agree with, but if we could all dream about what it might be like, that we might actually have a huge reduction in inpatient, and Eric Dishman is a health technology researcher, that we're moving 50% of the care perhaps out of the institution into the community. We would reduce SNF as skilled nursing facility, a nursing home, that we would reduce institutionalizing people quite a lot. We would increase specialty capacity, we would save people travel, and we would reduce the geographic disparities of care. And geographic does not necessarily mean rural and urban. As you well know, there are urban areas that have significant disparities in care based on where you are. So I thought what I'd do is quickly go through the different types of settings. And I'm going to start with the community rather than the institution to drive home the point that we're trying to think more about the community and the home. So some example, look at this. So this is from 1925, an envisioned future of how we might do care remotely. So I thought that was kind of interesting. Science and invention. There's the nurse and the physician, and I guess he's doing some sort of remote control of the exam of this remote patient. We don't do that, actually. Well, there are some remote robotics, but it's interesting. So that was 1925. So as many of you may know, the need is so important for us to remember of the aging population and the complexity of that aging population. And the cost associated with people with multiple chronic conditions is so disproportionate in terms of healthcare expenditures, 75% of healthcare expenditures. And again, as I said, we typically use the very episodic, the tune you up and send you out methodology because our system is frequently designed for that. But there's evidence that it doesn't have to be that way. And so I put the year of this particular study to highlight 2008. So this is dating back 5 years. And the VA has produced really important data for us for longer than that. The VA, if you think about it, has a very interesting model, whereas, and I heard a leader in the VA remind all of us that once you're a veteran, you're always a veteran. They are responsible for you for the rest of your life. So the incentive to really keep people healthy and comfortable and safe is very, very high, much more so than how most of us get our health care. And their data is very compelling for their community-based care. They have demonstrated a reduction in hospital days, a reduction in both bed days and as well as admissions, very high satisfaction, and savings in costs. They've also, through their well-publicized literature, shown quality indicators that are extremely important. Other researchers and other reports providing good evidence of how we can do chronic disease much, much better using a number of technologies. Again, reducing emergency room visits and hospital length of stay. There's other anecdotal and somewhat strong some literature around just the lowering anxiety, having a sense of community through technology and decreasing depression and anxiety. So again, I put these up here to show there's good evidence for this. How do we manage hypertension, diabetes, depression, etc.? A lot of good evidence. So where we've been, where are we going? Lots of interesting devices that help people connect, some with video, low-end video, some without. Some will ask me questions about how I'm doing. Some will take my weight and record it because I probably would lie about my weight. Some will put patches on my body and tell me what my vital signs are and record it so I can manage it, that I have a data point that's a concern and my provider has a data point that's a concern. This is for diabetes, the sensor. This may be, is any of this yours? There's one about to come up that's yours. So this is for diabetes, so that people don't have to prick, but they've got a sensor that can sense if there's an issue. This one's yours. Wearable jewelry that, again, grabs information from inside me and transmits it. If you can imagine, those of you who deal with data, though, transmitting all this data, when I present this to health providers, their head can explode. So at first, very exciting, because how meaningful is it? I went to the doctor, I was late, I ran, it was raining, I went for, I got in there, they take my blood pressure. Further than that, they make me get my weight, then they take my blood pressure. So it's a little high. So how meaningful is that value? Not very meaningful. If I had continuous information, our providers get very excited about that until they think, how am I going to manage that? So, but it's really much more meaningful information. Monitoring adherence, as you may know, older adults often are managing very complex pharmaceutical regimen, very complicated. This one before, this one with food, this one at night, very complicated. This one is a project with Citrus looking at off-the-shelf technology that can support wellness. We connect, my kids love that slide, for physical therapy. So being able to actually know, most of us don't do our physical therapy or physical torture, as some people call it, very accurately. This would allow for very real signals to be exchanged in a meaningful way. So that's where we might go. So at the end of the talk, we'll think about how do we get from where we are to where we go. I'm going to switch gears and talk about another setting, office-based. I use the word telemedicine here, so I'm already inconsistent, so forgive me. 1968. By the way, nurses hate this slide. I work with highly skilled research nurses. They hate this slide, but this is the old look of the nurse with the nurse's cap. Don't ever do that. But it's a historical slide. She's got this, I don't know, camera that she's doing. This was a model in 1968 for believe it or not, mental health between Logan Airport. I guess if you've been to Logan Airport, maybe you would believe that. But between Massachusetts General Hospital and Logan Health in Boston. This is another really well-recognized outpatient telemedicine program in Alaska. They actually use, because I made that note about informal caregivers, they use at best maybe high school educated people who are trained caregivers. This is a clinic. No, it's not a clinic. It's a community health center in a very remote area of Alaska. And this is the receiving end of those pictures. Oops, see, I got to move away. This is a former, actually, medical director here at Citrus, Dr. Jana Katz-Bell, doing infectious disease. So office-based telemedicine, real-time telemedicine, is relatively prevalent. It's a relatively small number of outpatient consultations if you look in the big denominator of outpatient telemedicine, but it's pretty recognized and pretty well known. It's not a new concept. Lots and lots of different video-based types of units can be sold and integrated and used. Lots of different devices. If we can stick it in you and get a signal, we can probably capture it and transmit it. It's not all done by real-time video. We have a really promising program. Actually, this was largely promulgated out of Berkeley from our School of Optometry here. This is a little tricky to say. So the most important way to reduce preventable blindness is to address the diabetic population. And so if you can get yearly retinal screening, you can find the preventable blindness and treat it. And a high prevalence in the Native American population, so this has been really well rolled out into a number of different tribal health sites around California. And again, a lot of efforts led here at UC Berkeley. And by asynchronous, as the term implies, I mean not real time. So picture taken, transmitted, read, and screened. So where are we going in outpatient work? I'm a mother of 3 boys, which is why I look tired all the time. And I would have loved this, which is a handheld otoscope, because if you're a parent, you have dealt with ear infections, I'm sure. So this is a handheld device that sticks on your cell phone and can be put in the ear and immediately rule in, rule out an ear infection. That would be enormously helpful for all of us. A Bluetooth-enabled stethoscope, so cardiologists get a little agitated at the idea that we might not... the stethoscope hasn't changed in decades. That's been the diagnostic tool. Isn't that interesting to think about? So this might change the way we do cardiac assessment. Another way we might change how we do cardiac assessment, my dad bought one of these. He had an arrhythmia, stuck it on his cell phone, and it transmits and records looking for any cardiac issues. Handheld ultrasound. This is, again, Javed Siddiqui. We are not supposed to do this. We are not supposed to transmit images by our cell phone. But this was an emergency situation where he had a video conferencing relationship with, Sacramento. He lives in Sacramento, and this was a relationship in Sonoma. And they called him, and I think we have a problem. He said, send me a picture, and you probably have done that. Has that happened? In the medical community, they get pictures on their smartphones. And the reason we're not supposed to do it is there's no way to integrate it with our electronic health record, and it's not HIPAA compliant. But it was an emergency situation, and he saved this man's life. It was what I call, medical people call it something different, but it's flesh-eating bacteria. Saved his life by getting a surgeon called in, and all done over a cell phone. So we can have very meaningful encounters over cell phones. I have used it to send what looked like a bad wound to a physician colleague, and he was not very impressed by my son's burnt knee. So as we look at new models of care, it's not all video-based and it's not all patient-driven. One of the best examples has been what is called Project Echo, which was started out of New Mexico. So with this idea, if you possibly believe that we will never have enough healthcare providers to address the growing population, the growing number of covered individuals in the United States, then you have to start doing a knowledge transfer. And Project Echo is an evidence-based mechanism to take what is in the specialist's head, create a relationship, an educational relationship with primary care providers, and enhance their ability in a specific area. So you create, it's a little bit not appropriate to say that, but a mini specialist in that particular area, a center of excellence. And that has been branded, and is now they're trying to take that to scale, that ability to change the dynamic between patients, providers, and specialists. A lot of consumer-driven online primary care. So this is Anthem Blue Cross and others. The idea that I can put my credit card in and for $45 have an online encounter, and these are really quite available with a primary care provider. And so if I'm a primary care provider and I want to work 2 hours and I'm available between 8 and 10, I can become part of this panel. So this is a very interesting dialogue that's shifting the relationship between primary care providers and patients. I mentioned that if you have cancer, which is a very, of course, unfortunate situation, and you live in an urban setting, your chances and your opportunities for clinical trials, another chance that you have is to participate in a tumor board. You might not know immediately that you're participating in a tumor board, but that is a multi-disciplinary setting where radiation therapy, nurses and physicians of all disciplines come and they talk about what's happening, because cancer is a very complicated situation that, of course, also has to be customized to the person's culture and choices. So these tumor boards exist in academic centers. They don't exist in the 1 or 2 doc oncology office in a number of medium-sized and certainly not small settings. So to address that, we actually have a virtual tumor board that looks like this. And it isn't the academic center telling everybody what to do. It is a true dialogue it creates a bigger network of oncologists and cancer specialists to look at all the different options. So this is something that is video-enabled and is really an important enhancement that couldn't exist to address cancer care in outlying areas. So that's some of, I'm going to go into pre-hospital and emergency settings also. So as you can see, hopefully you can see in the background, this paramedic is in a video link to a hospital, so that the pre-hospital, the ambulance field work could be much better organized with what's going to happen in the hospital, and that's actually what is seen in the hospital. We have, this is a picture of UC Davis, that's Dr. Jim Marson on the right. We've been doing video-based consultations for emergency care for pediatric for about 12 or 13 years. So I get asked a lot, why video? But a pediatric specialist is able to, by visually seeing the color of the child, the rapid breathing, the subtleties, make very different decisions than they would over the phone. And if you can avoid a transport for a child, we actually get a fair number. A sick kid, luckily, is very rare. But when it happens, it's very anxiety-producing for nurses and physicians in remote areas, and they ship quickly. So think about that from a parent perspective. You get shipped 4 hours away. You have other children at home. You lose your network. So if we can avoid those transports, it's a better quality of care. It's also a cost savings. And we can keep the hospital beds in the urban center prepared for the cases that really need it. So it's a very compelling case to share with you. I'm going to pause on telestroke. You've probably heard about the golden hour and the ability for a dramatic difference in your outcome if you are treated quickly. And the literature around stroke is very, very compelling. If we can administer a declotting drug quickly within the first hour, the outcomes are dramatically different. But if you administer it incorrectly, you do harm. What a strange sort of Greek ethic problem almost. You can do no harm, but if you don't do anything, you do harm. So the standard is that it must be ordered by a stroke specialist. There are not that many. And so what's interesting about telestroke is that the literature and the standard has become, if you don't have a stroke specialist, you really must consider using telehealth. So the standard of care is shifting because the evidence is so strong. And these are very strong studies that have been done, and this is an area that's really moving from pilot to scale. So in hospital-based telemedicine, another really interesting, fairly common, I'm trying to think, I think it's 15 or 20% of ICU beds are now monitored remotely. So the evidence, though, is mixed on this in terms of the cost and quality avoidance, but it's a very compelling area of if I can do 24/7 oversight of patients in an ICU, I can have a stronger outcome. Not only can I improve quality, I can improve throughput of those patients, which has a cost implication. So we're looking a lot at ICU coverage. I skipped over radiology because radiology is completely scale, teleradiology, so to speak. The sharing of images that are stored somewhere and interpreted somewhere is completely to scale. We did not experience a number of the policy and incentive barriers that we have experienced in some of the other specialties. You would think pathology would be right there too. It's not quite there. Some of the issues around image capture and data management have been more difficult with this particular specialty, but moving forward. So where are we going in some of these areas? Telesurgery. So we now, it's a standard in many areas to do laparoscopic surgery. Surgery using robotics is a fairly common area. This is an interesting story, and check out the date is very important. On the 7th of September 2001, they did a transatlantic robotic surgery with the surgeon in New York and the patient in France. And it was a huge undertaking, and then you can, of course, as the engineers will describe, the bandwidth, of course, phenomenal. Very successful operation. And the press conference was scheduled on September 11th, 2001. So it was a huge accomplishment that never really was shared broadly because of that, of course, extremely awful day. So operative mentoring. I'm not sure how many of you would volunteer to be the first remote patient to be operated on across the country, but what is happening is interoperative mentoring. So if you come to an academic center mid-career to learn new skills for a new procedure, you go back out and you're mentored by video. And that's really quite a successful operative area. So before we move into the policy, I want to tell you what's going on in California, because I think you'll be very proud. We are very well situated in California to go from pilot to scale. To go from pilot to scale, we need things in place. We need infrastructure. We need bandwidth. We need technical assistance, and we're going to talk about this more. And we have this. In California, we have the California Telehealth Network, which is a dedicated medical-grade broadband network for healthcare delivery. Citrus is a part of that. UC Davis is a part of that. It's a statewide effort, not-for-profit effort. We have a lot of grant funding in California to do new models of care. We are very privileged in California to have a number of healthcare-based foundations that are very supportive of looking at new models of care, specifically using technology. We have an interesting infrastructure that is a little competitive, actually, which is private clinician panels are really growing in the area of telehealth and telemedicine. I think it's an important driver because they drive competition drives entrepreneurialism and response. So these are groups of physicians that have come together and will go to an emergency department and say, for this fee, I will cover your psychiatry. Psychiatry in emergency departments is a big problem to determine holds and other treatment options that have to be implemented within a strict regulated time frame. So these panels are emerging, and that is creating an entrepreneurial spirit. And we have a lot of pilot projects. This is a project I was specifically involved with, which was a broadband technology opportunity program, which put $4 million and a lot of technical assistance money out into over 100 different sites around California to promote their new models of care. And that's just one particular project. So there's a lot of activity. All right, pilot to scale. So I think what I've been thinking about a lot in the last couple years is with all of those amazing ideas that have great promise, what goes to scale and what doesn't go to scale and why. And I don't know what you think about this graphic, but it's really about incentives. And what is the number one incentive in healthcare is, okay, it's a quiet group.
Staying healthy.
I wish. Thank you. It's money. And it's not a bad thing. It's the model. It's how money drives incentives. And I don't mean it at all in a bad way. But I think the models of care, and it gets back to that early slide, it gets back to now. So we as innovators have to dream about the future, and we have to keep moving towards the future, keeping people healthy, keeping people out of institutions. We, however, are driven by incentives that are in place right now. And that is a really difficult issue. And I think that's why we see what David and I were saying, a bit of kind of traditional telemedicine, video-based telemedicine. We can get reimbursed for that. We know how to do it. We know how to apply the current policies to that area. It's much harder when we talk about different kinds of remote monitoring or different devices. That's why this is a really important collaboration with Citrus. It's going to take multidisciplinary groups with policy, healthcare delivery, clinicians, engineers to make this work if we're going to really drive new models of care. Healthcare is a heavily regulated field and not a great adopter field. Banking, much better. Well, banking may be more heavily regulated now, but I'm not trying to make that similar. There are a lot of regulations that we need to be extremely aware of. And so if we get a new idea that's a pilot, we have to sort of go through a checklist of things to figure out what we're going to have to interpret. And we need to use very creative attorneys and policy people to help us interpret as we try and go to scale, sometimes so we can just do a pilot. We need to think about licensure. By that I mean professional licensure. Physicians, nurses are licensed practitioners that have a specific scope of practice, and they are licensed in a particular state. State by state. State by state. That's not helpful when you're trying to break boundaries. We are governed by the state. Accreditation. Hospitals have quality metrics, and clinics have quality metrics, and people that come and survey us for days at a time to see if we follow those quality metrics. Professional liability, which is the proper term for malpractice insurance. So as we do things different, we have to bring the insurance field along with us to demonstrate the impact on standard. I use the term standard of care. So when we started doing video-based telemedicine, and some of the medical malpractice insurance companies said, whoa, wait a minute, what are you doing? And that sounds really risky to me. And what if that equipment breaks down? And what if the right information isn't transmitted? Our response was, well, what a good dialogue to have. But what are the chances that two clinicians at the same time are going to make a negligent decision? Doesn't that sound actually better? So it's about that dialogue. Provider panels, and this actually gets to the states. So if our clinicians want to do care to Nevada, they have to be licensed in Nevada, and they have to be if they want to see Medicaid patients, they have to have a Medicaid provider number in Nevada. So we have to, I'm sorry for going through the laundry list, but I thought it might be useful to hear the checklist of things that goes through our brains as we think about adopting these technologies. HIPAA is actually pretty low on, are you familiar with HIPAA, which is this privacy and security mega legislation that regulates hospitals and clinics? And actually HIPAA is pretty low on our list. It's actually one of the, I would say, easier ones to interpret for us in terms of security and privacy, but we have to be cognizant of it. We have to be very careful about regulations that induce referrals or self-referrals. So if we have clinicians that start companies or clinicians that work other places, they can't do anything that looks like they're referring to themselves or creating business for themselves. So that's something we have to be very careful about. Internet prescribing gets its own bullet because it drives me nuts. Because it's really hard. There's been when somebody does something bad and using bad judgment in terms of what they want to do over the internet, it creates a huge snowball effect for all of the good work that we do. So internet prescribing has unfortunately fallen in that bucket because there have been some bad people who've done a few bad things. And so the legislation that then comes out to go, oh, that's really bad, there will be none of that. There will be no, you may not prescribe unless you lay hands on a person, which was a reasonable approach to try and address internet prescribing, would have halted everything we had done in telehealth. So they get their own bucket of frustration. Other sort of cultural issues about adoption and social scientists, I think, need to be brought to the table to help us with this. How much are patients going to, let's think about those monitoring devices, and let's think about keeping people and aging in place. How much are they going to want you as that child or that provider to know about what they're doing? Do they really want you to know that they walked that day, that they took their medication, that they ate healthy, or they had a chocolate bar? The intrusion that we will all decide to accept into our lives is a very interesting idea. We have to have a health professions workforce that embraces this, that embraces us as consumers coming in saying, well, I've been tracking my vital signs and here's what I know. Many healthcare providers do embrace that, but they have to work differently to be able to do that. And we have to think about the evidence that we use as we promulgate these different areas. So what am I excited about in terms of drivers of adoption? I think that no crisis should go unnoticed. So we're going to have a shortage of healthcare providers. We have to deal with that. One way is using technology, shifting the knowledge base, using different caregivers. We're going to see, this bullet has become controversial, hasn't it? Increased enrollment from Obamacare or whatever you want to call it. But the idea that there will be more covered people will require us to think about those populations differently. Timely access to specialty care. So as regulators demand better access, these kinds of technologies may move that. Consumer demand. So we saw this, I was sharing earlier that there was a conference in New York by the Parkinson's community. Strangely, consumers have been, I think, not visible in this, not demanding that they have a right to have access to a particular specialty. So I'm hoping we will see more activity from AARP, from different consumer groups that will demand that we as a healthcare community use technology more wisely and more efficiently. And the body of literature. So this actually is a citrus slide, but again, overused term, the perfect storm, looking at why I think we're going to see a demand for these kinds of technologies, and you all are going to play a role in that. I had to give a moment to the EHR because if we think about pilot to scalability, are you following how much money in the billions has been spent to how many, when you went to your provider last, were they using a paper record? How many of them were on the computer when you were at your provider? It's quite prevalent. Do you know why they did that? Why did they go to the electronic health record? Was it because they were going to save money? Because they thought it was a good idea? Why'd they do that? They got a incentive/bribe. They got money from the federal government to incent them to do that. And so if you think about the billions that have been spent to adopt an EHR because it's deemed a good thing to do for healthcare, we don't see that kind of investment in the other areas. And I think that's a very interesting issue. So there we go. So my question really in my own brain is, again, what examples of technology-enabled healthcare, and I sort of said them, have been the most adopted, and how can we learn from that and create policies and regulations and environment and a culture that creates adoption going forward using all the incentives that we have. So I am willing to take questions. I also have a pretty cool video that I'd be welcome to share. And David, I'll turn it over to you, what you would like to do.
Thank you, Jana. I think that this group would very much like to see the video.
Cue the video.
One more example, and then again, as you both put it out as an opportunity, but I think there's so many key issues for the different disciplines we have represented here today to ask how they can best interact with this forthcoming explosion in terms of telehealth.
Sure. So after spending those remarks saying how important we all think it is to bring care into the community, I'm actually going to reverse, because one of the things that motivates a lot of us is saving the life of a child. And this video shows a very dramatic example of that. It's a very personally motivating video. It's also been shown to the governor and others, which is an important policy opportunity because it just drives home the point that technology can make a difference. And we're very grateful to this family for allowing us to. It's very raw video. Let's see if we can make this work.
On August 3rd, approximately 5:30 in the afternoon, CHP officers were dispatched to a solo vehicle rollover. All 4 parties in the crash were transported to Mercy Medical Center.
I'm sorry, Jim. What kind of doses you use that?
0.5 per kilo BID. If you're coming up on 12 hours, it might be a suggestion to add a little glucose in that IV fluid.
Moving all 4 extremities, and wasn't liking our trip down to CAT scan, so I.
Wow.
That was the pre.
Wow.
So it looks like it's lifted up really well.
Yeah, luckily there's no penetration of the dura. That's great. I think that given what happened and seeing the injury on that CAT scan, it's looking like everything has worked out very, very well.
Can you say hi?
Oh, she wants her grandpa an ice cream.
She's been doing really great.
Yeah, that's super. And she's still a little bit puffy, I can see in the face, and that's going to get better too. You don't have to be a doctor to realize that was a serious injury. So.
But she's doing fantastic.
She's much better today. She got the JP drain taken out. She's been up playing, talking, active. Can you say bye?
Say bye-bye.
Can you wave bye-bye? See, he's waving to us on TV.
On August 3rd, approximately 5:30 in the afternoon, CHP officers were dispatched to a...
There we go. So, thank you. If there are any questions, we're happy to have a dialogue. Yes?
So we'd use the microphone if you don't mind for the questions.
So we should get back in the glare of the light.
I understand that electronic health records can't be guaranteed to be durable enough so that at the end of a person's life, for example, the descendants can review those records and use them to establish their own family health histories. So the durability of electronic records compared with paper records is widely recognized as a serious problem, and I'm wondering how it's being addressed in the healthcare context.
I'm not a medical and electronic health records expert in any sense of the imagination. When we've done implementation, we follow the typical guideline. The paper record is actually not also required to be in perpetuity forever either. So we follow the same legal requirements that we do for the paper record. I guess you're asking, there's promise there for it to be a forever document, and I don't know how to make that happen other than to say I think from a delivery system we have to have some reasonable boundaries around the expectations around our systems. But I welcome anybody else to respond to the promise issue more. See, as an implementer, I go, what are my regulations? What are my boundaries? Anybody else want to respond? What a good question, because again, you're thinking beyond where we are right now, but what could we really do now that we're implementing this technology? Other questions? Okay. Yes, sir.
Another question. Could you go back to your driver's slide about 3 or 4 from the end? I just want to look at it again.
Any questions for?
Was it this slide?
Yeah.
Or this one? There were a couple. Was there any question about or comment or conflict? Any of those drivers? I think there's a lot of opportunity. I mean, I think what sustains many of us is there's more excitement around the adoption now than I've seen in years, and I think it's a tremendous opportunity. And citrus is making a huge difference because, as I said, it's going to have to be a multidisciplinary effort. Yes, sir.
I have studied the British healthcare system, NHS's tendency to promote and encourage and purchase computerized cognitive behavior therapy. In the 2005 framework, they hired a company to produce beatingtheblues.co.uk. And have you heard of it? No.
No, but I'm always pleased to hear other international examples.
So a few years into implementing it at their county level, a free healthcare system in Australia, Mood Gym, one word, 7 letters. Have you heard of it?
No.
Oh, okay. So it is. The scientists who compared it found that Mood Gym was maybe better than the expensive one. And so if you look in the last 8 months on the nhs.uk webpage, the number of hits of Mood Gym has gone from 500 to like 1,000. So I'm wondering, you mentioned anxiety and depression and telehealth, and at 20,000 feet you mentioned it. So I wonder if you have looked any closer than that, and if it's actually sort of FDA approved in 7 countries, this Mood Gym. I'm wondering how would it penetrate California?
What a great question. Do you have more familiarity with it? I'm happy to share with you. We're lucky to have David
we
here.
can tag team on this. I am not familiar with that specifically, but I think it's a perfect indicator and an example of the challenge, because there's so many levels that works at in terms of why we, and at Citrus, we are doing work internationally with a number of countries who have, in some cases, wonderfully more advanced technologies. In other cases, are using ours. But there are so many organizational issues, interoperability issues, but coming back to both regulations and the financing are usually the drivers. A key issue that I think there are 2 important takeaways from that without being able to answer your question directly. One is the need for anticipating changes in technologies and in delivery mechanisms. One of the key things that we're looking at now is the importance of building long-standing platforms that can adapt and really adjust as the technologies change, whether they're paid for or free, but there are so many changes occurring so rapidly. It's looking for that longer-term solution that can roll with this area. And I really commend that to all the engineers in the room, the issue of how you create uniform platforms that can build this, and also the interoperability issue. If there's going to be a major challenge here, it's how to link all these areas. But then again, you do get to that financing issue, which is also central to this. And from a national health system perspective in the UK versus our still fee-for-service, even though we're moving towards accountable care organizations and bundled fees, we still have a ways to go in terms of being able to adopt programs like that.
So let me try to make this more blunt. Why don't all of the physicians in California, when they have a patient presenting with anxiety who has no money, why don't they tell that patient, Mood Gym, webpage? What's blocking because it's a treatment that's approved by the FDAs of about 7 countries. Mm-hmm. So all of the barriers are gone. The only barrier left is promotion. And I've gone to counties, and the top county health executives don't know about it, and they're embarrassed they don't know, and they have this engineer telling them about it. Mm-hmm. And isn't there a better way than me so I can go back to work?
Yeah. I think it is promotion, as you said. So who would fund that promotion and that education would be a fundamental barrier, I think, which is interesting. And I think that there are people that would. there are foundations that are interested in safety net populations and underserved populations that might fund pilot work to see if that's effective. And then one of the other barriers potentially in our country that doesn't exist is we have this uninsured population. They go and do something, but then they maybe can't get a prescription and they can't get medication. So there's that follow-up, that's that integration issue that David said that is a struggle. But good ideas often do start with that pilot work and through the healthcare foundations in our state. So it's good to know.
And I think we'd love to talk with you offline, because this really is an indicator of the key issues about what happens in the case of telehealth, telemedicine continuously. Pilots, wonderful pilots that are successful, or in this case, a program that's been implemented and adapted by multiple countries, yet dissemination of information and findings, the broader adoption, as Jana has been saying, we have fundamental barriers ranging from just sharing of information to resistance, either from providers who this can be threatening to them, to, in our case, where we've done many, many different programs with hospitals and health systems, all of whom are given data that shows the effectiveness of a remote monitoring solution, for example, but still say, no, we have to do it ourselves. There are many different cultural, subjective, yes. So I think you've really raised a great point here. We have just time for one more comment or question.
I wanted to see if you could just give me an idea of approximately what proportion of prohibitive regulatory, sort of things against innovation in this country are federal as opposed to state by state.
Excellent question.
We should quiz ourselves.
Right, that's an extraordinarily challenging question.
State, both.
We actually can both refer you to our colleagues who run the Center for Connected Health Policy that has been affiliated with UC and Citrus. They are based in Sacramento and do a wonderful, they've done a review of all 50 states in the telehealth area. Not necessarily all technologies, but also organizations, some of the larger associations, the American Telemedicine Association, have reviewed that. And just a personal observation, I think it's quite mixed, and I'd say that particularly in telehealth, the state issues are still fundamental in terms of, as Jana was perfectly identified, the issues particularly between the ability of different professions to work across state lines, those type of regulations and the variability in them. More on the reimbursement issues, that really goes to a federal issue. It's as much reimbursement as it is a regulation.
Yeah, I think you can do a lot at the state level, though, to promote innovation. And honestly, some of more, I feel like what is a barrier is more this slide. I feel like the policy issues, there's such a grassroots great connection in this field to promote good policies and we have a relatively policy-friendly state in California. There's been so much work on that, but I think more of it is, I feel more of it is related to some of these drivers, some of these cultural barriers that we actually just talked about in terms of promotion and financing models of care that work, that aren't really state or federal. They're how payers are willing to pay for a population. So it's all fronts, I think. What do you think?
Well, yes,
on that
exactly.
Note?
But I think on that note, that's a perfect way to challenge us in some of the issues that are still out in front. This is not an area that, if anything, it's just going to continue to grow so rapidly, and the issues, the complexities of it are there. And again, Jana, for taking the time to both explain and give some wonderful examples, thank you so much. You really gave a beautiful overview of this whole space that we can take away from here. So would you please join me in thanking our speaker again for such a wonderful program.
Thank you for having me.